I'm thrilled today to announce our guest speaker, our keynote speaker today for Economics Forum, Dr. Keith Dreyer. Dr. Dreyer is the Vice Chairman of Radiology at the Massachusetts General Hospital and an Associate Professor of Radiology at the Harvard Medical School. He's not only ABR certified in diagnostic radiology, he has a Bachelor in Mathematics, Master's in Image Processing, a PhD in Computer Science, and medical fellowships in both Imaging Informatics and MR. He holds numerous board, chair, advisory and committee positions with the ACR, with the RSNA, the Society of Imaging Informatics in Medicine, and numerous global healthcare corporations. He has authored hundreds of scientific papers, presentations, chapters, articles, and books. He lectures worldwide on digital imaging standards, medical informatics, image sharing, clinical language and understanding, clinical decision support, meaningful use in various electronic health record initiatives. We are so lucky to have Keith with us today. In his presentation today, he's going to explore information technologies such as EHR and decision support as they are relevant to us in our practice now and as they will be increasingly in the future. So thank you, Keith.
Thank you, Geraldine, and thank you all. I didn't know about your relationship to John Sullivan, so I'm going to start my timer to make sure I don't go over. What I want to try and do is take you through a roadmap that I see. Many of you have probably lived through radiology in the last 20 years and the big technology influence that has happened, information technology such as PACS and RIS. And I want to kind of give you a picture of what's going to happen, or my vision of what's going to happen over the next few years, in large part because of healthcare reform and what's been spoken about so far in this session. So first, let's just set the playing field level here and talk about the current state. I think it's pretty safe to say that the payment models that we've had for the last 2 decades have really set toward fee-for-service and incentivized volume and been fairly neutral on value. And these business models have determined the innovation that have occurred for us, maximizing productivity and volume and reducing our costs. They really weren't optimized for performance metrics such as quality, safety, access, and outcomes. Now, I'm not saying that none of us have done that, but when you look at the technology that the vendors have provided us, and you sit on the advisory boards of those vendors, they've driven toward productivity and volume and reducing costs. And it's these incentives that have fueled the innovations that we see today. Take this example. So if you were a radiologist advising a PACS company, maybe your PACS company, to this question, if they asked you, they said, when an ordering physician is pondering a difficult case that you've recently interpreted, what would you want that system to do? What would you tell that PACS vendor to do in that particular case? And I would argue that it's based on your incentives. So if you had no incentives, you really probably wouldn't even participate in the discussion. You wouldn't have time for it, you'd be doing other things. But let's say, as it has been, based on volume, you'd probably say something like, provide the ability to order more imaging. Let that person say, are you having trouble looking at the CT? Maybe you want to get an MR in this case. On the other hand, if you were driven by outcomes, if that was your incentive, and you discussed this with the vendor, you'd probably say, why don't we open an instant messaging session because I want to try and help them to understand the case, the complex case, and I want to be able to prevent them from ordering further unnecessary imaging if that was the situation. Let's take it one step further and say, what if you were incentivized by patient interaction or patient-directed care? And you might say, well, let's expand the last functionality further and open a chat between you, that physician, and the patient. So I think you can see that a lot of where we're at today has been based by the fee-for-service system. And as you've heard in previous discussions, that just may change. And so if so, what does that mean for us? Well, let's look at some of the resulting technologies that have come to us: RIS, PACS, web distribution, speech recognition, all based on these prior business models. And another one, teleradiology. And this one I find kind of interesting because we think, and we all know what we mean by teleradiology, but when you step outside of radiology, you step outside of imaging, and you start talking to regulators or individuals outside of even healthcare, teleradiology seems like a little bit of a misnomer. What we've done is we created secure access for remote radiologists, essentially for ourselves. What we didn't do is provide access to our regional colleagues, or our competitors, if you will, that are equally taking care of patients in our domain or in our community. We also didn't give access to patients. So we spent a lot of time creating technology for teleradiology. A lot of businesses have been created, but the systems are pretty limited to be able to give remote radiologists access. And obviously, these were initially created to improve productivity and convenience around those business models that we discuss. And it serves to further reduce costs through such things as economies of scale and geoeconomic shifting to lower cost centers throughout the world. And the unintended consequence of this is the potential to serve as a conduit for commoditization, which has been discussed here as well. So it's not always that you get what you want when you do technology innovation, but it is largely driven by business models. So if you look at these innovations that have occurred, RIS, PACS, speech, advanced visualization, 3D image distribution, teleradiology, and you kind of create a grid of different metrics such as productivity, profitability, performance, things like quality, safety, and presence or relevance of us in care. I would argue that if you sum these up, you'll see something like this. These technologies have increased our productivity, and associated with productivity is profitability in the days of fee-for-service, increased performance, but our presence, our relevance has really decreased because of this, because of the remote access that we have now. We don't have direct one-on-one contact with a lot of physicians. Well, health imaging reform is really kind of changing the dial on our business models. I don't want to spend a lot of time on this because there's great presentations in much further detail than I can give, but suffice it to say that we're spending an incredible amount of money in the United States on healthcare, and as such, whatever health reform occurs, cost is going to be primary concern. As exploring alternatives to fee-for-service, such as episodes of care, bundled payments, accountable health care, I think that the shift is going to go, the risk shift is going to go from payers to providers, and probably even further extending to service lines such as imaging. But this time, unlike the 80s with HMOs, we're going to have to monitor and report on quality, safety, and access. And I think probably the most widely accepted method for this, using the various mechanisms for quality and safety, and the most widely implemented is CMS EHR incentive program Meaningful Use. And I'll talk about that in a little bit, but suffice it to say, 5 fundamental goals are to improve quality and safety, engage patients and families, care coordination, population health, and ensure privacy and security. Those are the pillars of meaningful use, and underneath those are ways to make sure that we and all physicians and hospitals are adherent to those guidelines by creating objectives and measures and various stages of meaningful use, which I'll talk about in a few minutes. So this new era of IT, as I see it, I think innovation is occurring again in a big way. There was a little bit of a lull as the market saturated for RIS, PACS, and various other technologies that are out there. But if you think pre-PACS and post-PACS, our world changed considerably. I think something similar is going to happen again, and there'll probably be, once again, a digital divide based on the adoption rate. So if you're an early adopter or a late majority adopter or a laggard, you're going to be in a different location on this curve as opposed to others, and you'll see a digital divide probably occur as it did before. This time it's going to be around a concept of imaging health records, and I'll describe what I mean by that. You know, when meaningful use first came out, our response in radiology was to tell the feds, we already do digital. We are far advanced, far more advanced than anyone else, any of our specialty colleagues. We've been doing digital for decades. But I would argue it's not quite like the government sees it. So today's imaging environments, I think our imaging information is too insular, too compartmentalized to ourselves. We've created silos of our own information. I think the transition will occur so our RIS, our radiology information systems, the functionality that's at the enterprise level is converging into these electronic health record systems that are being deployed at our institutions to be compliant with meaningful use at the hospital level. And these are such things as ordering, scheduling, and various forms of communication. So what happens? Well, exemplary of that is if you track and trend RIS becoming electronic health records and being shown at RSNA for the last 3 years, year on year that's been doubling. But what happens to the rest of the RIS technology, the departmental functionality for RIS? I think you're going to see that converge into PACS, because it's not going to make sense to have a half of a RIS or 2 RISs in part in the EHR and part just sitting inside a small department. So I think instead, things like work list, workflow, interpretation processes, which before used to in part be driven by RIS, I think are going to transfer over to PACS. So it'll be this new world of EHR and PACS, the non-image data and the image data, if you will. But beyond that, we're going to be required, if you were at yesterday's resolutions, looking at some of the ones around image sharing and the late resolution 53, around requirements to move images outside of our domain, image sharing beyond our institutions is a necessity. And so just like the old days, if you were around in the days of PACS in the 90s, when web solutions came out, but we didn't replace our PACS, we just bought layers on top of it for web distribution. And then about 5-10 years later, web PACS came out. I think you'll see the same thing here. There'll be image sharing solutions, and PACS will be separate, but it won't make sense to sit there for long. But that's what will supply our EHRs and our patients, as was discussed for the California chapter in Resolution 53. But I think it's safe to say that that will be replaced by what's known as imaging health records. EHR companies have no interest in putting imaging data inside of their EHRs. It's too difficult. They claim there's no interest that they have, so it's going to have to be performed somewhere else. And I think that's going to be in these newly emerging imaging health records. And similar to RIOs or HIEs, health information exchanges that are in place to exchange text data of health records, we're going to see something similar, as was mentioned yesterday, the RSNA image sharing network funded by the NIH, to allow imaging health records to be able to transcommunicate information back and forth. So that will allow EHRs to be able to receive patients' image data in the future. So I think that this is going to be more of the platform that we're going to see growing as time goes on. This health information exchange connecting text data and imaging information exchanges connecting what used to be called PACS systems that will be imaging health records going forward. And this old concept of the silo of a RIS and a PACS that don't communicate well outside of the departments are going to go away. So what will be the drivers that are going to take us here? What are the things to watch out for? Because this isn't going to happen overnight at every institution. It's going to slowly happen over time. I think it's going to be based on meaningful use. The drivers, I think, will be the carrots and sticks that move this process forward. Meaningful use is a voluntary CMS incentive program to promote the use of a new term now that we get to use called CERT, Certified Electronic Health Record Technology, to improve safety, quality, and cost of care. The incentives are somewhat substantial in the $50,000 range per physician participation, and penalties up to 5% for future non-participation. This all came about in Obama's first term, his first week of office, where he announced we'll lower healthcare costs, cut medical records, errors, improve care by computerizing the nation's health records in 5 years. Shortly after that, meaningful use legislation was passed. About a year later, the first regulations were passed for stage 1, which described how radiologists were essentially included through this process. In 2011 began physician and hospital participation, receiving the incentives. In September of last year, stage 2 regulations were defined, and the incentive payment period lasts 5 years. So if you want to participate in those incentives, you have to do so before 2016 when the time on the incentives runs out. But the penalties kick in the beginning of 2015. To date, payments are over $12 billion, and this number is expected to go to about $25 to $30 billion. So what does meaningful use mean to radiologists? Nearly all radiologists are eligible for the program, but compliance can still be challenging. And I think it's because we, our industry, our vendors were late to the game to provide the technology that we needed to do so. If you look at most recent data coming from CMS, looking at, as of January of this year, the number of physicians who can participate compared to those that have gotten paid for participation is about 32%. So 32% of all physicians that can participate are. What do you think the number is for radiology? It's far lower. It's 7.8%. So when you think about the notion of a digital divide, we're essentially starting one ourselves with our physicians. But yet there are a number of vendors who have technology solutions available and have taken radiologists to attestation and helped them to receive their funding. But as I say, when we look at this curve, physicians are moving ahead of us in the meaningful use curve. And so when they ask things from us that they need to have with regard to imaging, we might not be able to supply it to them if we're not participating. And this is important because the stages of meaningful use are year on year. So the first year, stage 1 is 2 years long. It takes that long to get to the next stage. You have to participate in stage 1 for 2 years until you get to stage 2, 2 years, stage 3, 2 years, and there'll be continued stages. So you can see if you start late in this process, you're going to be late to advance to the future stages. It's like starting late in college. It's been challenging to help radiologists to understand what it is that they specifically have to do and what technology they need to put in place because depends upon if you're in a hospital setting, a private practice setting, if you're academic, if you have imaging centers, if you have multiple hospitals, if you do teleradiology, if you do mammography, interventional, things are different. And so rather than read the 4,000 pages of regulations, the ACR and Mike Peters and the government relations staff have done a great job of helping to define this specifically to radiology. Recently, I created a simple website just called DoYouMU that can guide you at least to look at one of the 6 buckets that you'll probably drop yourself into. And it's just a simple answer the questions, and you'll wind up to see where you're at the end of this and see if you can participate and what ways you might be able to with technology that you already have. So let's say you're not going to do it. Let's say you're of the 90% who are not participating yet today of radiologists. What else could happen to you with this? Well, I think ordering physicians doing their meaningful use compliance are going to expect things from you. And those are new requirements that are coming out in stage 2 that won't be active until 2014, and they're optional, but they're already starting to hit our doors, such as the California chapter with the resolution yesterday talking about how do we get imaging results, the images themselves, back to those physicians' electronic health records. And these are around image ordering and image results. And a roll-up of what the regulations say is basically by 2014, as an optional measure, image ordering using CERT, physicians have to order 30% of their imaging exams using their certified EHR technology. So not a phone call, using their CERT to place the order. And more arduous, when they place those orders, 10% of those have to result in images coming back and being either connected, linked, or embedded into their electronic health records. So think about what this means. An ordering physician at a facility that's not related to an imaging center places the order, and that has to get transferred over to the imaging provider. The image that gets created has to somehow make its way back or link back into that ordering physician's certified EHR technology or some certified EHR technology. It could be the radiologists. But it gets more complicated because we serve multiple physicians, and those physicians probably use multiple imaging providers. So you can see the complexity here that's happened in the last few months since this came out in September of last year. We'll talk about some solutions for that in a moment. But I think this is a good time to introduce the technology as I see it behind Imaging 3.0. And to that end, I think the ACR has to make aware these technologies and frameworks, obviously to you, the members, but also to the federal government, to the regulators, to help them to understand what it is that they're asking of us to do and what they're asking of physicians to do as they step into image management and image health records. But it's also very important for us to educate, as we did in the days of DICOM, educate our industry partners, such as the technology vendors and even the providers and the payers, on the platform, this technical framework for Imaging 3.0. I see it as an enabling platform using already the standards that we have in place, like IHE and DICOM, and extending those with content such as the appropriateness criteria, and then creating application sharing so we can share amongst the applications that we've created and will create, but more importantly, have industry access so that the application that you've already purchased and hospitals have purchased, we can integrate into with these layers. And so I'll just talk a little bit about a couple of these just to give you a feel for how this would go together. So let's talk about clinical decision support, because that's been mentioned recently with the appropriateness criteria and ACR Select. So what we would do is take an application and connect it in at the appropriate point in industry, which is through the electronic health records, CPOE, PHRs, et cetera. And so what we do here is the goal is, because today's imaging environment is payers regulate the use of imaging via pre-authorization and RBMs, and that limits the way for radiologists to participate in the management of care on that ordering component, how would we change that? Well, in the Imaging 3.0 environment, we would use such things as clinical decision support for image ordering, providing tools to assist the local radiologists in utilization management by incorporating national standards and imaging guidelines at the point of care at the time of order. And this would be directly integrated. It wouldn't work if it wasn't integrated into those million-dollar, billion-dollar systems that hospitals and physician groups are buying for their certified EHR technology. And so first what we did over the last 3 years was translate the PDFs and the information in text inside the appropriateness criteria into a large database that has web service access for the EHRs to be able to have timely information all the way back to the evidence that substantiates the guidelines. And this is essentially, you can think of as columns of imaging procedures and rows of clinical indications that give the scores that we know about in the appropriateness criteria of 1 through 9. This is a functional prototype of a user interface for the data that we have embedded inside of the ACR appropriateness criteria database. And so in this case, if I query by saying I want to order a CT of the head for dizziness and ataxia on a 42-year-old female, this automatically checks off the boxes of what it was that the natural language processing understood. You can check off more. It opens up to the clinical scenario that's appropriate, and it also fires up the scores to say what you're about to do is a 7 out of 10, but there's other alternatives. MR angiography is an 8. Other things are higher than that. And that's embedded into the solution that people use for ordering the exams. So when you think about it, the digital divide that existed because of the placement of electronic health records, which made radiologists distant from the ordering process. Physicians maybe no longer called or came down to the department. They just type on their computer in their EHR. Now we have an opportunity to interact with them in an intelligent way. So when exams are straightforward, they can order, but if there's things in questions, we know when it's time for us to interact, and we can also include the payers in this process by eliminating the RBMs. There's a difference between clinical decision support and utilization management, and I want to make this distinction. I feel pretty strongly that rules themselves, so if you just place them into EHRs, those alone will not control utilization. I think I heard that yesterday with Brent James' presentation at Intermountain as well. Utilization management is best performed locally, in my opinion, and it's by providers of local medical imaging experts, such as the radiologists at the facilities where the clinical decision support will go in place. So I think this is an enabling, not a disabling technology. I think the funding should come from those that are at risk, whether it's the payer or the provider that are paying for the systems and paying for the care. But the goal is to manage unnecessary use of medical imaging and the associated costs. So if you take Massachusetts General, where I work, as an example, we started this process 9 years ago. And in those last 9 years, well, 10 years now, clinical decision support rules were funded by our hospital system. And the tools were integrated into the hospital's electronic health record solution. We realized early on that without that, no one would use it. But the utilization management that makes the system work is controlled by the decision support in the EHR, as well as radiology and the chief medical office. MGH Radiology is compensated for its utilization management activities by the hospital, and MGH has staved off RBMs because of this for the past 10 years. Radiology is fully engaged in the process, so we're not disintermediated, we're in the process. And the results are high rate of appropriateness and managed utilization rates. And this has really positioned us for this notion of imaging at-risk contracts. So let's look at another example. Radiologist decision support. So as we create applications which are sorely needed for radiologist decision support, because that will be required also by meaningful use, probably speech reporting is the place where that would integrate into. So in my mind, reporting has been for us unstructured, unmanaged, and unidirectional, us out. And I think that's a quality, safety, and relevance concern that's going to be noted by the feds. The opportunity here is to create structured reports, and I would think of BI-RADs for the rest of radiology. Not every single word is going to be structured, but there'll be actionable findings and recommendations. And Rich Duzak did a great job of giving us a prototype to think about simple structure for findings and simple structure for recommendations. And this is early days, but I think this is probably where this is going to head. Similarly, radiologist clinical decision support has been important to us at MGH, for example, where we want to have consistency of reporting incidentalomas regardless of which one of our 100 or more radiologists are dictating the case. So Giles Boland, Tariq Al-Qassab have worked on a system for us to be able to have, as I say, a consistent algorithm that is embedded into the speech reporting system. And I think something like that is probably what will expand out from the ACR in working with vendors as well. As we expand to communication management now, what is that going to look like? So in this particular case, we've got speech reporting, which is important for us to generate the communication that's required, but we also have to engage the EHRs that the clinicians are using so we can have direct access to them. And in this, in my mind, we have to have structured bidirectional communication. Critical results is a pretty straightforward thing that all of us have to do for JCO, but the challenges are, how do you detect it? How do you create these kind of things inside the radiology report? So in working with Nuance, they have triggers that fire that you can set requirements. Say, in this case, there was a gender mismatch identified, but at the closing of a report, it also noticed that there was a critical test result, which was a fracture of C1 vertebrae, and it notes that, and you can make that a critical result if you want to. And you can define the critical results that will be detected by your radiologist And I would question that probably with time, the American College of Radiology will help to define what those critical results will be. But more importantly, after that happens, your critical result management and reporting will take place inside the EHR. So most recently, one of the EHR vendors, Epic, came to us and said, can you help us to make sure that we're in sync with what your vision is for how to report critical results inside of our system? And as you know, or may not know, Epic is providing EHR technology to about 150 million covered lives inside the United States. And so as we affect this, it will affect a lot of care throughout the United States. And our goal here is to have a consistent mechanism, regardless of which EHR vendor is participating in delivering this information, but equally important, giving that information back to the radiologist, and from our perspective, closing the loop. And the goal of this is to engage the radiologist back with the ordering physician and patients through communication management of systems that already are in place, our reporting systems and the physician's certified EHR technology. And finally, let's go back to this more complicated example, and I won't go through this because of time, but suffice it to say that how are we going to solve this problem that was mentioned yesterday with the Resolution 53? And I think there's 3 solutions that are probably going to emerge. The concept of solving that, getting the images back into the ordering physician's EHR could be as simple as pushing the images to the certified EHR technology of that physician. But think about that. Remember what I said earlier, EHRs are not going to hold images. That's not what they do. So in this particular case, we'd either have to dumb down that study into maybe a PDF and then pray that the EHR technology will be able to take that, or we'll need to move it into something that could be digested on the other side, which is probably an imaging health record, which the physician probably won't have. So this will be a challenge. Second, we can link images to physician certs. And this is similar to what, if you work inside of a hospital setting, you probably already do in your hospital, but it's a little different because it's inside of a firewall, where you basically connect up your web distribution or your PACS system image visualization tools to the hospital's electronic health records, so when they read the report, they see the patient, they click the button, and the image comes up. But try to get that work outside the hospital at multiple EHRs with multiple PACS systems. There's no technology to do that today. So I think that's what's going to emerge over the next year that's going to solve some of these problems. And thirdly, what we can do is provide images inside of your certified EHR technology and give the physicians access. So that'll help them to meet their 10% requirement. So all of these are so new, and the regulators, ONC and CMS, have not defined specifically beyond the details that they have today which one of these will probably be the most directed way to go. But in any event, what will happen is our image sharing applications, should we choose to make them or extend them from things like Triad, as well as RISP, PACS, EHR vendors, and image sharing vendors, and meaningful use vendors, will create the same platform for application sharing to allow them to be able to communicate, similar to the rudimentary days of DICOM, but at a higher level in the stack of the enabling platform. So let's go back to this diagram that we drew before on the current state, which was looking at productivity, profitability, performance, and presence from the technology that we've most all had in place now for the last decade or more. And we had this curve or this effect on those metrics. Now, what's it going to look like in the future if all this technology that I propose is going to take hold? Things such as image sharing, structured reporting, advanced communication technology like we discussed, imaging clinical decision support, radiologist clinical decision support, electronic health records, patient health records that include imaging components in all of those. I think we're going to see a change in this curve. I think as long as profitability is attached to productivity, I think we're going to see both sides of that curve drop there. And performance is going to increase because that's how we're going to be gauged, that's what we're going to be required to do, is demonstrate safety, access, and all the components of meaningful use and other accountable care organization requirements. But we'll also see a big increase in our presence or relevance in care, I think, because now we'll be more engaged in the process, albeit in a digital sense, unlike the old days, but we will be more engaged compared to how we are today. So the question for you at the end of this is to think of, and this was mentioned earlier, how do you keep profitability up when your productivity is going to change? And I would argue that it's probably best to think of ways to tie it to performance as opposed to productivity. So just in quick summary, I think healthcare reform is clearly changing how we practice. There's no doubt about that. But the informatics and innovation is equally as transforming because of these changes in our business models. Imaging 3.0 for us is serving as a framework. I mean, think about in the days of PACS and RIS and speech, really, it was all pioneers. We really didn't know what was going to happen to us over those years of putting that technology in place and putting it together. Teleradiology is a good example. So I think we need to actually create a framework to know where it is we're headed and to help those vendors to understand, as it takes 2, 3, 4 years to build software, what is the vision that they have to step into and how can they maintain profitability in a time of uncertainty. And I think creating these IT tools or even helping to have vendors create the IT tools centered around this framework is going to be critical. We also, without a doubt, need to educate us, ourselves, the members and the profession about all of these new paradigms, the framework, as well as the new tools and technologies that are going to extend because of the changing shift in healthcare reform. We also, though, need to educate legislators, as the GR group has done a tremendous job of, but also providers outside of radiology and our industry partners as well. And just shamefully, I'll promote our annual Informatics Summit, where we do these kind of things. We meet with legislators, industry, providers, and yourself. And this next one is coming up at the end of this year in October 10, 11, right here in DC. Thank you very much.